I'm going to be talking on Dr. Sushmita's next talk, Cataract Surgery in Pterygium. She's not here, and the other talk she sent as a recorded video. I don't know if that works. This is mine. No, no, this is yours. Yeah, yeah. No, in this I don't need the audio. In the next one. इसमें नहीं, next one. All right, so I'm covering Sushmita's talk, which is cataract surgery in with pterygium. I think as general ophthalmologists, cornea surgeons, or in general, every surgeon who is dealing with pterygiums and cataract surgery, all of us are seeing these patients. So the dilemma always is: are we doing a combined surgery? Are we doing pterygium surgery first? And if we are doing pterygium surgery, how long are we waiting? Now, I think the thumb rule is if you can do your pterygium surgery first, unless it's very small, like say like just a millimeter onto the cornea. If it is grown onto the cornea significantly, it's always better to do the pterygium surgery first. Wait for minimum 3 months, let the topography reading stabilize, and then you go ahead with your cataract surgery. But more so if you're planning any premium IOL, like say a toric IOL or a multifocal IOL, if it's a larger pterygium which covers the visual axis, if you're seeing recurrent pterygiums, if you're seeing double-headed pterygiums, if you're seeing any irregular astigmatism, then I think because I see a lot of patients where both the surgeries are just done at the same sitting, and then patient comes back elsewhere, and they're coming back with these residual errors, not very happy patients. If you're doing higher end IOLs, then definitely I would say you need to do your pterygium first and then cataract surgery. Now, when are we going to do a combined case? Like I said, most likely you should avoid doing that, but there would be some patients where it's very small, patient just wants that for cosmetic purpose. If the astigmatism is like say 0.75 and or lesser, or logistically there are some patients, we deal with all strata of patients. If the patient comes from the periphery, doesn't want two surgeries, and that case you may go ahead with a combined case. So I'm just showing this one video where I'm doing the cataract and pterygium combined. So what you're going to do is first you're going to go ahead with your pterygium surgery, the cataract surgery, and you can do these cases topical. I am doing it topical, actually. There is no block in the eye. Once you've done your, can you switch off the light, please? It's not being seen. Nothing is being seen. I don't think my videos in my first talk was. Apparently, the whole thing is central. He's saying it's shutting in the all over. Are you shutting it? Yeah, I know. Nothing's really visible. Yeah. So should I continue? Yeah, okay. So after you've done with your cataract surgery, then here the pointer I wanted to go give is that when you are trying to excise the pterygium, most of us have a tendency to go like 3 or 4 millimeters away from the limbus. So do not do that. I would say that you need to actually excise right near the limbus, because if you see, the conjunctiva actually retracts and pulls back, and most of the bulk of the pathological conjunctival tissue is near the limbus. And if you feel like in the residual conjunctiva there is some pathological tissue, you can always go back and excise, rather than, if you can see already it's retracted so much. So make sure when your first cut starts at the limbus. And here you can see I'm just holding it with the limbus, with the limbs, and I'm just peeling it off. It actually comes out very nicely like a rexis. You can see you get a nice smooth bed. I have not really used any instrument like a 15 number blade, nothing. I mean, you can always use it later on to make sure you're removing any of those residual tags onto the cornea. You can see you get a nice bed that way, rather than going first with a 15 number. Make sure you're always stripping it. Then that way, once you get that plane, you get a very nice clean surface. Now, following that, here I'm showing this because, if in some, like I thought if there's some student in the audience, I don't typically mark all the time, but I feel this really helps. You go ahead and you measure the area of the pterygium, Then you go ahead and you mark it how much you want to excise. As you can see, patient is really moving his eye, and it's being done under topical, but it depends on the pain threshold of the patient. If the patient is feeling uncomfortable at this point, you can use little bit lignocaine and inject it subconjunctively here. It helps to give you that nice bleb and separation, so your dissection here becomes much easier. So once you've done that, you have to make sure that you are it should be very thin. You don't want any tenon. So what I do is I just once you've got a nice graft, I just keep it on to the cornea and make sure that your assistant at this point is not injecting any saline on the cornea. Here I'm using glue. So you put the glue, and then you use your two instruments and just place it, and it like works very beautifully well. If you do not have glue, obviously you're going to use sutures. I know some people use blood and all. I really don't use that, because I want a nice cosmetic result at the end. Then you pull your conch here. You can wait for minimum, I would say, wait for if it's a younger patient, especially with a very strong facial, wait for at least 5 to 10 minutes, dry that bed completely, and use your vanas to cut any excessive glue. This iris repositor, I think, works very well to nicely flatten that graft out. So and if you feel at beyond the edges, if you want to just ensure that the conjunctiva is stuck well, you can do that. So I think that's the end of my presentation for pterygium. Sushmita's recorded video, can I just put that on? You'll need to give me an audio input. Yes, please. Yes, yes, Samita. A lot of these patients are very keen, they want a good result. So, and of course this was combined with cataract. Even if you're doing the pterygium first, when the most likely is come to you just for the cosmesis, so make sure that you're and that's the reason I also don't block because in pterygiums, though I know a lot of patients do with surgeons do with block, because then you end up with those hematomas, and which you don't want. So I'm just going to play Sushmita's recorded video. Can you please come here? One of you can come here.
Morning, everyone. I'm Dr. SUSHMITA SHAH.
Endothelial dysfunction. I think endothelial dysfunction, first of all, it is important to diagnose it, because a lot of times, especially if you're not dealing with corneal problems, then it is very important that you look at the corneal endothelium properly. There are guttate, because as a general ophthalmologist, you're operating these patients, and then they come with unresolving edema, like they're going around and taking other opinions. So if you've not diagnosed it, diagnosing it is really harmful for your own image and practice. So make sure you're diagnosing it properly. And because why is it important? First of all, counseling. You can tell the patient that this is going to be a two-step surgery. You may need a corneal transplant, or you will need a corneal transplant. And also the biometry, when you're planning, because if you're going to be doing cataract surgery in a patient who's got Fuchs endothelial dystrophy, and you don't budget for the biometry, then the cornea surgeon who is going to do a DSEC in him or a DMEC in him later, or even when you're doing it, he's going to have a huge hyperopic shift. So aim for myopia. Now, while doing surgery, if you want to do both of it together, what is important is that there's going to be a lot of corneal edema, so there is going to be poor visualization. So removing the epithelium always helps. And in these cases, because you're not worried about the endothelium, you're always going to be replacing it anyways, you can use do most of the surgery close to the endothelium and not near the bag, because your visualization will be poor. If you do it near the bag, you can get a PC rent. Always, always, always use a cohesive viscoelastic. If you're doing a combined case, do not use a dispersive viscoelastic. I've seen, in fact, when I was training in the US with Dr. Flugfelder, I've seen his cases where, once the staff gave him methyl cellulose and he just used it, and he had a detached graft the next day. So this is something, which you need to remember, because oftentimes if we are doing more of volume of cataract surgeries, we don't remember. So use only the Helon viscoelastics, because they will be removed completely. Do a smaller X's, because you don't want the IOL popping out of the bag once you're doing the dealing with the cornea. And the Desmet strip will be done after phaco with the OVD in place before putting the pilocarp in. So this is a video which I'm playing. Like I said, it's just like a routine cataract surgery. It's not something different that you're doing, but you just follow all these tips. Use trypan glue. As you can see, most of the phaco is happening in the anterior chamber here. because the visualize, I mean, in the video it doesn't show, but when you're actually operating these patients, the visualization is quite poor. So you need to make sure you're not making a rent. And here you can do DSEC, or you can do whatever technique you want. And here I'm just doing the easiest technique which even a general ophthalmologist can follow. You just have a pre-cut tissue and you push the cornea in, and the patient really does well. So thank you, and I apologize for our speaker not being here, and I hope it was a fruitful session. Thank you.